Welcome to the rtx1 e-symposium. We are very glad to have today among our guests our two chairs, Professor Peto from Queen's University, Belfast, as well as Professor Errera from Pittsburgh School of Medicine. You might already know that the rtx1 adaptive optics camera has been already used in more than 200 published articles that can be clinical studies or reviews. And we are very happy that today 6 presenters will tell us more of what they are doing in terms of cellular level retinal imaging and microvascular retinal imaging in their research using this device. And our second chair today is Professor Errera. She is a clinical ophthalmologist specialized in retina in vitreous. She is now an associate professor at Pittsburgh University, and she's building bridge between medical specialties to improve standard care of patients. In addition to clinical work, she is part of the collaboration between Pittsburgh Eye Center and Paris Institute of Vision.
Yes, so in that session, you will hear about imaging of retinal arteriolar vessels, but about imaging rtx1 at cellular levels also. I will introduce the first speaker of session 2 is Professor Michel Pack, Professor of Ophthalmology and Researcher at 1520 National Eye Hospital in Paris and at the Vision Institute in France. His focus is on medical application of high-resolution in vivo retinal imaging in humans. He pioneered the development of cell-specific imaging using SLO and the application of adaptive optics ophthalmoscopy for a variety of retinal diseases, including AMD and chronic diseases such as arterial hypertension. At the Clinical Investigation Center at 1520 Hospital in Paris has been leading clinical research projects encompassing rtx1 imaging for more than 10 years. Today, present an overview of finding in hypertension, as well as methods that were established to extract biomarkers using rtx1.
Thank you, Marie-Hélène. We'll share my screen. Does everybody see my slides?
Yes, yes, we do.
So thank you for the organizer to invite me to talk about the topic of the usefulness of vascular morphometry to manage arterial hypertension. It's, of course, a group research, so these are the name of the person involved in this research. So as you know, arterial hypertension affects vessels, including vessels in the eye, but also in the brain, the kidney, et cetera, et cetera. And the eye, the only accessible tissue for examining vessels, and thanks to rtx1, now we can measure very precisely the morphometry of arteries, not only the diameter, but also the wall, which gives access to the parameter, which is a Walter-Henry ratio that we alluded to in previous talk. We've been developing this is our standard protocol. We usually image the entire vascular arcade. We usually image 1, maybe 2. That doesn't seem really useful to analyze all 4 arcades, and it's also quite time-consuming. And we also developed, with the help of another lab, a new segmentation software in order to increase precision of the measurement. So we were among the first to publish the fact that indeed we can measure increased Walter-Henry ratio in the hypertensive population. These are the first graphs that we published. But there are 2 issues. First, there is still a cloud of points rather than a straight line for the correlation. So the correlation does not seem to be very strict, which could be a good or a bad thing. It could be a bad thing because it means, okay, it's not very precise, but it could be a good thing because it may integrate other parameters than simply blood pressure, which is, of course, of interest for application. We also noticed that imaging can detect focal arterial narrowing, which is a sign of focal vasoconstriction, which I will not talk much about today. The question is, what is the added value of this measure? Because the interest is, of course, to have a surrogate of brain circulation, especially what is called cerebral small vessel disease, which focuses a lot of attention from neurologists because it's a background lesion in which stroke may develop. So we've been developing a standard measures or standard protocol for such measurements. So usually in most publications, it's recommended to measure Walt-Whitman ratio close to the disc, but we believe that may be an alternative site, which is at the vertical of the fovea, because everybody has one or two arteries passing horizontally through the fovea, well, most of the subjects, and it's easier to capture, and it's easier to train a technician. Just go on the fovea, go up or down vertically, and you capture the first horizontal artery. That's what we call now the reference zone. And it can be also detected on the montage, because it's where the axon starts to So we compare the measurement in both locations. This is a population of hypertensive and controls, and one measure was done close to the disc, and the other one on the right was done on our reference zone. And sorry, the square is not well placed on the image. It should be a bit lower. It's not in the artery. Sorry for that. So you see there's a more clear difference between the hypertensive and the control population if you consider this reference zone. So that's why we believe it may become a standard in order to diminish the size of the cloud of the correspondence between the double Walt-Whitman ratio and blood pressure. So we did this is a cohort we're currently working on with neurologists, this patient with having some risk factors, and we're currently longitudinally examining them to detect any change in the Walt-Whitman ratio and the correspondence with the occurrence of neurovascular events. It's an ongoing work. We also been looking at patients with malignant hypertension, very severe hypertension that requires hospitalization. And we were measuring over time the variation in diameter of arteries. So we see two examples here of the same patient. And bizarrely, as we were expecting vasodilation after the crisis, in fact, some patients continue to diminish the size of their vessel after the crisis. So in this particular situation of severe hypertension, even after treatment, there may be some vasomotor phenomenon occurring, which blurs the relationship between blood pressure and vascular diameter. That's maybe why there is some cloud of points instead of a straight line. Maybe vessels integrate other parameters and then simply blood pressure.
Sorry, time to conclude.
This nice image of you see here the focal narrowing that resolves over time. So this is of course of interest to understand disease such as stroke. We've been developing with the help of ImagineEye neurovascular coupling, flicker stimulation to vasodilate. That's another way of phenotyping the vessels. And we did already validated this method of another cohort of patients with
we're going to, thank you very much, Professor Pak. We're going to invite to talk now Professor Kyoko Gosho, ophthalmologist also. She currently works as a researcher at Clinical Investigation Center in 15 National Eye Hospital in Paris. She's also visiting associate professor of ophthalmology at the Nippon Medical School in Japan and visiting ophthalmologist in Kobe Eye Center. She has dedicated her research to translating new ultra-high resolution retinal imaging techniques from laboratory inception to clinical adoption. Our ambition is to contribute improvements in both the prevention of diseases and the personalization of therapies. In Japan, she has been conducting clinical research studies on inherited retinal dystrophy using the rtx1 camera. In Europe, in a European project, she contributed to the development of a novel retinal imaging device and its validation in clinical settings.
Thank you very much for introduction, and hello everyone. Thank you very much for inviting me to present here today. So I'd like to talk about my experience with the IRD using the rtx1 and the new machines. So these are all my co-authors and COI. Thank you very much. So now new therapies such as gene therapies, cell therapies are coming. So there is a need for imaging cells in the pathological retina to understand the cellular mechanism, to detect early change, to get the early readout of the effectiveness, and personalize the new therapies. It is why I have been using the AO rtx1 camera more than 10 years. So I think AO images enable as co-mosaic phenotyping in IRDs and early detection and diagnosis and assessment of the IRD progression. So I'd like to start with several examples of the IRDs using a rtx1. So this is the first example, the peripheral cone dystrophy case. Please note the perifoveal cone disappearance and the distinct RP pattern around the foveal cones. And second, this is the occult macular dystrophy. So it shows the different pattern of the cone disappearance and was also reported as a starry night pattern. And this is the asymptomatic central area choroidal dystrophy. And the phenotype was described as cone disappearance in the central broad area. And we could measure and assess the visible cone cell density. So this is a study of autosomal dominant retinitis pigmentosa caused by HK1 mutation. So this mutation is known to cause RP with a late onset in late 40s. The proband case, a 49-year-old mother, had very low visual acuity and suffered from almost complete cone loss in the peripheral area. Both daughter had BCVA 20/20, but the only who had mutation in HK1. So the cone density reduced by approximately 40%, even she was 20 years old. So in this case, it is likely that cell damage was detected and quantified many years before the appearance of the visual symptoms. So this is a report from Dr. Uedo, Nagoya University, Japan. So this is an example of the rtx1 was used to not only measurement of the cone density, but also pathological feature in the retina. So it is a follow-up study of the macula of the patient affected by RP at the late stage imaged with the rtx1. So OCT confirmed that the photoreceptor was still present in the gray central area. Over the years, rtx1 image allowed to measure a very slow shrinking of this zone. And even in the intervals of the time when the patient visual acuity remained stable. So in this study, it was remarkable that the RP progression as measured from images seems to occur at a similar rate in every patient. So now I'd like to show the new system. So I've been working in the European project. So it is a Merlin project. So the new multimodal multi-scale imaging system. So it has large field images as SLR, OCT, OCTA, and then we can choose the region of interest. Then using AOE, adaptive optics technique, then we can see AOCT and AOSLO and AOCT angio. So we can see the detail of the retina in 3D. So this is the cone dystrophy case. So we can see the photoreceptors and we can detect the transition of the photoreceptor visibility in AOSLO. So this is the RP case with the rtx1 and AOCT and AOCT. So we can see that in the one where we can see the photoreceptor, actually we can see the outer segment of the photoreceptor in AOCT. So this technology might offer new possibility for regional phenotyping and clinical research. So this is
30 seconds left.
Yeah, I will skip this one. So this is my conclusion. Thank you very much. Yeah, I finished.
Thank you very much. So Gosho, I'm sure there will be plenty of questions for you and for Professor Pak. Let me introduce you to the last speaker for today, Dr. Pam Utink, who is working for Erasmus University Medical Center, Rotterdam, Netherlands, and graduated from medical school in Rotterdam in January 2021 and started a PhD in inherited retinal dystrophies under the supervision of Professor Caroline Clever and Dr. Alberta Tiadens. Dr. Utink has been graduated also from Master Health Sciences, National Institute of Health Sciences, Erasmus University, Rotterdam, with major in genetic and molecular epidemiology. Dr. Uting started working with the rtx1 in 2022 in the Adaptive Optic Vision project led by Erasmus. Adaptive optic vision aims at improving the detection and management of inherited retinal dystrophy by developing biomarkers for adaptive optic images using artificial intelligence methods. I have a question first for Professor Pak, if I may. I'm the moderator, so I can decide, perhaps.
Yes, you can, please go ahead.
So, Professor Pak, I understand that you saw a few changes in the arteries diameters in your patients with hypertension. How useful are the result for the cardiologist? Does the cardiologist ask you about the diameter size of the artery? Do they make any change in their treatment?
Yeah, that's a crucial point. Bringing biomarker as a useful tool for monitoring the therapy beyond blood pressure, and that I think is a crucial point. To make a long story short, we have several arguments for the concept that vessel diameter react very slowly to change in blood pressure. I mean, if your same patient goes into your room, you do several measurements of the Waltman ratio, you have always the same end. But if you take the blood pressure over several minutes for the same patient, it's higher when he goes into the room because of a bit stressed, and then he calms down. So you may have, let's say, 16 size systolic, 160, and then 100, you end up with 120, for instance, in the same session. But the WLR will not change. That prompted us to check what is the time change in blood pressure that needed to observe a change in Waltman ratio. Another argument was derived from a patient we saw with severe hypertension. When they come to a first exam in our lab, blood pressure is always normal. There have been a long list of treatment, but blood pressure is okay. Still, the vesicle diameter is very Waltman ratio is increased from 0.35, 0.40, which is over the normal. We know it's not their normal Waltman ratio, even if we didn't have that value before the crisis. So that's another argument for us to say that maybe it's a history of the past blood pressure, and that's the whole point for cardiologists. It's like in diabetes, you have the glycemia, but also the hemoglobin, glycated hemoglobin, and maybe the rtx1 will be the same. I mean, you have the blood pressure while you see the patient, but also it may provide information about the past blood pressure, maybe several days or several weeks, which give a better reflect of the adherence of the patient to treatment. That's why we want to start a prospective study comparing patients, comparing 24 hours ambulatory blood pressure measurements to the actual values of WLR to see if it's better correlated to ambulatory measurement than to immediate consultation blood pressure measurement.
Thank you very much. So you bring the research to the clinic.
Exactly, and outside of ophthalmology, general medicine. I think that's
general medicine. Definitely, you can make a change. Have you, by any chance, have you measured the vessels, the vein of your patient, the vein difference? Because there are some patients with varicose vein, hemorrhage, so they might have some changes in their vein as well.
We know that patients with severe crisis of high blood pressure do have vein dilation, that's for sure, and it decreases after the crisis. What we don't know yet, if it's chronic, in chronic hypertension, there is variation of veins. It seems to be in studies using fundus photograph that the dilated vein have a prognostic value for death, meaning the larger the veins are, the more cardiovascular event occur. We did not look at that parameter in our patient. That was interesting to look into. The problem is we don't have a reference value. We have a WLR as a reference value without any dimension, so it's easy to have normative data. It's not the same for veins.
Thank you very much. And for the, I have a question, if I may, to Professor Gosha and to Dr. Hetting. You showing, I'm sure that all the audience is thinking the same, but they are too shy to ask. You're counting, both of you, you're counting the cones. Sometimes the RPE cells as well now with this new module. But how do you do? Is there any tool provided by rtx1 to do that counting? Which type of tool are you using, both of you?
When I use for the publication used for the IRD cases, I usually use the AO detector provided by the ImageNice and but with the manual collections. So I compare with the several method and I found it is more easier but it's very time consuming sometimes, but it is a more repeatability. I think it's much higher. And so I usually use AO detector.
Thank you very much.
Yes, for me the same. We also use the AO detect, but with manual correction.
Thank you.
And then with a second researcher who also have a look, because sometimes, yeah, I was really in doubt if I saw a cone or not, but then we did it with more people. But I think, yeah, the AO detect is really accurate, and especially in the healthy volunteers, it works really well. But of course, in the more severe disease, yeah, sometimes it's harder. But then, yeah, we had to look with more people and then we came to a consensus.
Is there any question for the audience? No? And I have another question because you know that recently, I don't know if you know, but recently for geographic atrophy, severe geographic atrophy, dry AMD, we have a treatment now, injections every month or every 2 months of a medication into the eye. And there are a lot of controversy about that treatment. It says that it will just slow down the area of atrophy, but the clinical trials just show that perhaps it's reduced, but it slowed down this atrophy at 1 or 2 years, but there is no improvement of vision yet. We don't know how to tell if it's working or no. They rely on on autofluorescence to show it's working. Do you think that maybe some interest in rtx1 to better show an efficacy of this type of treatment better than autofluorescence?
I found when we studied for the GA a very long time ago for the using the rtx1 and the hypo, some pigment clamp. We found in more than in the autofluorescence image, the rtx1 has a more precise, and when I tried this, only a few cases, but it was much, precise detail could detect by the rtx1. So I think, so now with the TFI and the rtx1, I think we can study a bit more precise and a very short time and a more small change in the short time. I think it is what I'm willing to.
Thank you. Someone, Monsieur
Yes,
Chateau, you want to add something?
Yes. So what we could demonstrate based on the data from the Cancer Hospital at that time is that with the higher resolution, we get a much better delimitation of the atrophic areas compared with autofluorescence or even OCT. So based on the rtx1 images, it's possible to measure changes like expansion of the atrophic area borders in quite short times, like just a few weeks. Now, I don't think we have data on photoreceptors in geographic atrophy. So we can certainly measure the expansion more precisely than AF, but I'm not sure if we are able to characterize the photoreceptors in these elderly patients as well as we can do it in younger patients, like in IRDs. What do you think, Michelle or Kyoko?
Yes, I remember when I tried to measure, I was so surprised in 1 week, 2 weeks, we could see the difference in the AO rtx1. So I'm certain that now maybe it's, we can be able to measure the change in a short time. But to measure the photoreceptor, it's another story, I think. So it is more difficult, it's like they spare the region, so it's more blurred and it's still difficult to distinguish each cones or photoreceptors. So yes, so atrophic area is able to measure the size of the area, but not each, cone numbers. It is, I don't know still, but for me it was very difficult, yes.
rtx1 is to be combined to autofluorescence in the new research, in the new clinical trials with this new medication. I was perhaps, when I talk about this medication for geographic atrophy, I'm thinking of SYFOVRE medication, SYFOVRE. Many of you are familiar with this new medication for geographic atrophy. Is that the only one we have so far?
Yeah, confirmed that bizarrely photoreceptors disappear quite early in the process of AMD, even at early stages, even of obtrusion. It's very difficult to ascertain the presence or not of photoreceptors. And so there's a loss of contrast or something related to the interaction with the RPE. So it is indeed an issue that we did not solve properly yet. But for the growth of GA, I think, yeah, that rtx1 is very, very sensitive to growth of GA lesion, and maybe it may even serve to distinguish responders from non-responders of therapy, because therapy is a monthly injection and it's a very lengthy treatment. So maybe deciding rapidly in a matter of weeks, this patient responds, so okay, go on. This patient does not respond, maybe we should stop or increase the dose. Maybe it's also an effect, dose effect. I think there are many questions that can be solved, at least in part, by the rtx1.
Thank you very much. We have a question from the audience. Is that the right moment to ask? It's a question for Professor Gauchot. Are there other biomarkers in adaptive optics images besides photoreceptors counting that could be used for the follow-up advanced inherited disease?
Yes, normally I found many people use the photoreceptor counting, but I found that there is, as I showed you from the Nagoya University team publication, they measure the area of the photoreceptor preserved area. So I found it was super great idea, so to measure the size. And so it is the one I saw, and the other biomarker, I don't know exactly. Yes. I hope it's going to be the answer for the question.
So, well, thank you everyone for today's great discussions and presentations. I'm just seeing that it's 3 minutes before the end of the event. So I would like to thank very much all of our speakers and the chairs for the animation. And before people disconnect, we have a final small poll. With this time, it's questions to help us at Imaginize maybe improve when we organize this kind of events. So there are 3 questions. We would be nice to hear from the people in the audience to be able to adapt our offer of interactive events online like this to what is feasible for people to join. So I'll let it run, and in the meantime, of course, I want to say a big thank you again to our chairs, Professor Tunde Peto and Professor Marie-Hélène Errera, who were really kind to animate this meeting, and a big thanks also to all of our speakers today for sharing their work their insight, even their methods to everyone in the room today. It was a great session. Thank you, everyone.
And for the users of rtx1, don't be shy asking us when you need to interact about image interpretation, or if you have special needs for image analysis. We are here to help, or put you in contact with other people who can help. Thank you all.